Okay, we're going to start out with our next trivia question. So again, first person that gets my attention with the right answer, so wave or whatever you need to do. Okay, and this one is for a $50 Regal movie theater card. So get your hands on those buzzers ready to go, okay? Okay, name one non-motor symptom of Parkinson's disease. That's motor, non-motor. Loss of smell, okay, yay. Wow. Okay. Okay. One other announcement on the Hawaii Parkinson's resource table here. We have some examples of books that are in our library, and there's a partner to this book. These weren't to take. So if you accidentally took this book, if you could, discreetly return it by the end of the symposium, right? Okay, our next topic is going to be on bowel and bladder. So why do world travelers have bladder issues? They're incontinent. Okay. Okay, our next speaker is Brianna DeWitt. Brianna is a doctor of physical therapy and specializes in pelvic health and oncology rehab. She's been practicing on Oahu since 2015. She's a firm believer in movement as medicine. There's a theme there, guys, right? Brianna has become a certified Pilates instructor and prefers to blend Pilates principles with her rehab knowledge to facilitate movement and optimize recovery. She's passionate about prevention, wellness, and holistic care in her practice. In her spare time, she enjoys farmers markets, cooking, traveling, spending time with her husband and son. So I'd like to welcome Brianna DeWitt, Dr. DeWitt.
All right, let's see if I can figure out the microphone stand first. All right, thank you all for having me. Thank you to Hawaii Parkinson's Association for having us all here. This is such a great resource for you all to come together and learn. And thanks to Dr. Gal for getting me to be here today. So I'm here to unlock a new level of physical therapy for you. Raise your hand if you've had some physical therapy already. Raise 2 hands if you've had pelvic floor physical therapy. Okay, we've got a few. This is so exciting. I'm excited to tell you a little more about what we can do for bowel and bladder trouble with Parkinson's disease. Thanks. Yay, okay. Simple as on and off switch. Hi, guys. It's not my first time, I swear. Okay, so just a little more about me. I'm a doctor of physical therapy. I have my bachelor's in health and human performance, my doctorate from Eastern Washington, again, 10 years in orthopedics, pelvic floor, and oncology rehab, and I am a certified Pilates instructor, so that may be a topic for another day. But today, we're going to talk about what is pelvic floor physical therapy, what does bowel and bladder health normally look like, and what might it look like for you if you have Parkinson's disease, or if you're just a regular human in the audience, and some ways that you can start today to improve your bowel and bladder health. So, if you've seen a physical therapist, you know we want to know what's your coordination, your strength, your flexibility like. The only difference here is that we have a lot of specialized postgraduate education in assessing your pelvic floor muscles specifically. So those muscles sit in the bowl of your pelvis. So they are internal muscles, which require an internal assessment most of the time. So we have specialized skills to help you understand if your muscles can contract well enough to help you hold back urine, stool, and gas, and also to allow you to relax well to be sure you can empty everything out. Those muscles also have a role in sexual function and core and hip stability. So it is a really big, important group of muscles, especially if you're having any trouble holding back urine, stool, gas, or otherwise, which we'll talk a little more about. So the bladder, its job is purely to store urine until it's a more convenient time to empty. We don't want things just going right through us, so that bladder is super important. As it fills, it stretches, and that stretch is what signals the brain that we need to go. So you might get a light urge, gotta go soon. You might get a much stronger urge, we gotta go right now or else. But generally, what our daytime and nighttime patterns should look like is that we should go every 2 to 4 hours to empty the bladder during the day. We should not be waking more than once at night to use the restroom specifically. You might be waking up for other reasons, but hopefully it's not your bladder keeping you up. You shouldn't have any trouble starting your urine stream or emptying the bladder completely. And you shouldn't have any involuntary loss of urine. So what are some common things we might see with Parkinson's disease? And this is not an exhaustive list, but these are two of the most common things that I'll see in the clinic, but also just in general, we'll see with Parkinson's disease. So you might experience an overactive bladder. You've probably heard this term, but what does that mean? It means you're going really frequently, so more than every 2 hours. These are people who are like, oh, I go once or twice an hour. I can't get anything done. I really need help with this. It also might just be that you get a really strong urge to go and you can't hold it back. You got to get there like immediately, right? So that could be what overactive bladder looks like for you. It's important to remember that as humans, there are other reasons why you might have an overactive bladder, not just related to Parkinson's disease. So we want to make sure we're screening that medically in case there's anything else going on, right? You also could experience urinary incontinence. The two most common types we see with Parkinson's disease are urge urinary incontinence. So again, I gotta go and I can't get there in time. You have a little leak on the way to the bathroom. The other thing that is quite common is called functional incontinence. So that means you get a normal urge to go, you get up, but your mobility limits you from getting there on time. So addressing your mobility needs may be important in this case. There's other kinds of incontinence like stress incontinence, if you have a leak when you cough or sneeze or lift, or overflow incontinence. If your bladder has a difficult time telling when it's full, it can overflow. Okay, what can we do in pelvic floor PT to help you manage any bladder issues? So after we assess and we know exactly how your muscles are functioning, how your posture looks, how your general mobility looks, we might do pelvic floor exercises. So if you've ever heard of Kegels, squeeze, 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 stop the flow of urine, we might do those. But most likely, you'll need a combination of that with other exercise. And again, we just heard from Becky how important exercise in general is. It's also important for our bowel and bladder health. So we will talk about that. We will definitely talk about bladder retraining strategies. So what's normal? How can we get you from where you're at to closer to a normal voiding pattern? That might look like teaching you how to suppress the urge when it comes on really strongly and help you hold it a little bit longer. It might look like timed voiding, which you can do on your own or you can have a caregiver assist. So that just looks like scheduling your bathroom breaks throughout the day so you have a safe time where you know you can make it there successfully. And then we also will definitely talk about making sure you're adequately hydrated. If we're not taking enough water in, it's going to be really tricky for your bladder to feel comfortable if it's dehydrated. So we want to make sure you're taking in enough fluids. Again, we want to manage your mobility needs. If there are things like strengthening or functional training to get you out of bed safely so we can decrease the risk for falls as you approach the restroom with that strong urge, that is super, super important. And we might address equipment needs. Do you need an assistive device maybe just overnight to get to the bathroom safely? Do you need a bedside commode so the restroom's more convenient and you're having less leakage? We'll also talk more about managing constipation. If there's a lot of stool backed up, that puts unnecessary pressure on the bladder, can make you feel like you have to go sooner. And this last one on the list is kind of a more new and exciting approach. There's a lot of evidence that this is successful in managing overactive bladder and urge incontinence in the general population. It's also been found to be effective for people with spinal cord injury and multiple sclerosis. And there's currently 2 studies ongoing looking at it for Parkinson's disease specifically. But if you've ever heard of a TENS unit, which is just a home-based electrical stimulation unit, you can have this at home and you can use it daily for a period of time or for maintenance long-term. But essentially, you put 2 little stickers just right on the inside of the ankle. That nerve helps to override the sensation of urgency or that overactivity in the bladder, and it can help reduce your symptoms. So that could be an easy way to help you a little bit at home alongside all of the other cool things you learn in pelvic floor PT. All right, moving on to the bowels. Dr. Young is going to talk a lot more about this, so we'll keep it pretty simple. But generally, the colon is moving stool around and out of the body. So it's our waste removal system. Generally, what's normal is to go between 3 times a day to 3 times a week. So a very wide range of normal, but we want it to be consistent for you. We don't want you having extended periods where you don't go, and then all of a sudden you're going a lot. You should have nice, soft, formed, easy to pass stools. You shouldn't feel like you're straining. And you shouldn't have any involuntary loss of stool or gas. Cool chart. Everyone should have this in their bathroom, in my personal opinion. So constipation, again, is probably one of the #1 symptoms you'll see with Parkinson's disease. And it sometimes is even one of the earliest signs you'll see, even before any of the motor or cognitive symptoms develop. So I guarantee that when they say that up to 70% of people with Parkinson's experience constipation, I think that's a low number. I think it's underreported. So I want you to have some strategies to manage this before you leave today, which we'll talk about. But constipation can either be firm stools, so that type 1 or type 2, more pellet-like, small, difficult to pass stools, compared to our healthy type 3 and 4, somewhere in the middle, like toothpaste consistency. Definitely, we don't want you on the other end of the spectrum either, towards those more loose and watery stools. But constipation can also mean infrequent emptying. So if you're going less than 3 times a week, or you have those firm stools, this is you. Otherwise, there can be fecal incontinence. This can result from long periods of constipation where everything gets backed up for so long that little bits of stool sneaks out around it. Or it could be from muscle weakness. You're not able to hold back that stool or hold back gas when you want to. So those are some things we want to tease out with pelvic floor physical therapy. What else might you learn besides Kegels or not Kegels or exercise in general? Actually, exercise is like one of the best ways to manage constipation. Get moving. Your muscle contractions help to move stool through the colon. That's super, super important. Bowel retraining might look like teaching you how to position yourself on the toilet so you can empty more easily. It might look like looking at your dietary intake and your fluid intake to make sure your fiber and fluid is balanced, so that helps your motility and gets that stool moving. And we also, actually, any person with constipation and any regular human, I will teach bowel massage too, so we're gonna learn that in just a minute. But that is another mechanical, external way to stimulate your GI motility. So, today, I want you to be able to take home 3 things that you can do now to help with your bowel and bladder health. Number 1 thing is making sure you're well hydrated. So I should have put a big asterisk here, but unless it's medically contraindicated, you want to aim for half your body weight in ounces of water a day. That sounds like a lot for some of you, right? If you're not there, don't go from 0 to 100, but just gradually increase your fluid intake to help you with your bowel and bladder health. You can track this on a log or in your phone throughout the day just to see how you're doing. Some days might be better than others, but your goal is ultimately to ensure you're properly hydrated. For the bladder specifically, you want to try to stay in that 2 to 4 hour window. If you're going much less frequently than that, you could try scheduling your bathroom breaks. Let's see, can I go just maybe 15 minutes longer today and see if I can make it successfully? And as you get used to that, you can stretch out that interval over time until you're in that nice happy window where you can be productive and you can go for your walks or you can do your household chores without interruption. The other thing that's important with that is trying not to go just in case. I think a lot of us get into that habit of, I'm going to go quick before I leave the house. I don't know if there's going to be traffic. But if you have a pretty good idea that it's only going to be maybe 10, 15 minutes to the next place, try to wait until you get there. Okay? And the last thing, we're going to learn bowel massage. So the important thing to know is that after we chew our food, we swallow, the food goes to our stomach, through the small intestine back and forth, and then it comes up the colon through the right side of the body, over to the left, and then down and out. So we want to facilitate moving that stool out from the end, right? So I'm going to go back to this slide for a minute. So if we look at this bottom picture over here on your right, we're going to do a massage called ILU, or I love you massage. So if we start on the left side, and you can all do this with me, massage down from your ribs to your hips in nice clockwise circles. It's gentle. You don't have to be aggressive. You're just gently moving things along. So 2 or 3 times down the left side. Notice if you feel any firmness or if anything's a little tender. That might be some stool backed up. And you can do a little extra vibration. So it might look like this. You're pulsing, pulsing, pulsing. Sorry, I wish I was 10 feet tall. Then you could all see. And then you're going to come up to the right side of the ribs. You're going to massage from the right to the left. This is your L. So we did I, now we're doing L, across the ribs and down to the hips. 2 or 3 times, nice and gentle. And don't worry, everyone, I'll share these slides with you for later. Good. And then you're going to start at that right hip. You're going to come up the right side, go over to the left and down. So this is your U, going up the right side, over to the left, and down to the left hip. Okay, so you can do that every single day. I like to have people do it right before bedtime because you're laying down, your stomach muscles are relaxed, your body's relaxed, you're going into that rest and digest mode. So do it right before you go to bed in the hopes that in the morning you'll wake up and things will be ready to go. Okay? So I hope that's a good place to leave you with some practical tips that you can start on now. Of course, I'm going to be here later to answer all the questions you may have, but thank you so much for being here, and thank you for taking an active role in your health and learning all this good stuff today. Thank you so much.
I hope you didn't massage too much because there's not going to be another break for 30 minutes. Okay, one more trivia question here. Let's pick a good one. Okay, this is an easy one. Okay, but we'll do it anyway. Which famous British singer and Black Sabbath former frontman revealed that he had Parkinson's disease? Ozzy Osbourne. $50 California Pizza Kitchen. Yeah. Okay, our next topic, kind of a theme going on here. Our next joke as well. Let's see. What kind of camera do they use for a colonoscopy? A Go probe. Okay, our next speaker is Dr. Kraig Young from the Queen's Health System. He is a board-certified gastroenterologist at Queen's. He was born and raised in Hawaii and attended Washington University in St. Louis, Missouri, earning a degree in human biology with a focus on neuroscience, followed by a medical degree at University of Hawaii Manoa John Burns School of Medicine. He went on to complete a residency in internal medicine at Boston Medical Center in Massachusetts. Well, that said that terrible. After residency, he pursued additional fellowship in gastroenterology at Los Angeles County and University of Southern California Medical Center. I'd like to introduce our next speaker, Dr. Kraig Young.
All right, hi. So I don't have slides like everybody else, and I don't do Pilates either. But yeah, I met Dr. Gao in Boston, and she moved here, and I'm from here originally. So yeah. Iolani, and there's the Iolani Family Fair. I'll be working at the Fry's from 7 to 10 p.m. Just a shout out there. All right. So although Parkinson's is mainly a motor disorder, there are a lot of non-motor symptoms like gastrointestinal symptoms. So the point of my short talk is to kind of go over or highlight the most common GI symptoms that you might have, and then maybe some practical therapies that you can do before seeing a GI or neurology doctor. Okay, so starting from the head to toe, what you can have is things like drooling and difficulty with swallowing. This can lead to problems with eating, drinking, malnutrition, weight loss, but medically, we're also concerned about aspiration. That's when food or liquids go into the lung instead of your stomach. And that can lead to major problems like pneumonia, hospitalizations, things like that. Traveling down to the stomach, the main thing that we worry about in the stomach is gastroparesis, also called, slow emptying of the stomach. If we double click in that can also lead to malnutrition and difficulty with absorption. Specifically, the levodopa medications used for Parkinson's, gastroparesis can play a large role in the absorption of this important medication. The gastroparesis can manifest with symptoms such as bloating, nausea, vomiting, discomfort, and these are all things that I see in clinical practice. Moving into the small intestines, the small intestines can cause something called small intestinal bacterial overgrowth, where your good bacteria is diminished and you have pro-inflammatory bad bacteria that grows, leading to also bloating, changes in stool, problems with absorption as well. Like Brianna also talked about, we have constipation down in the colon. This is one of the most common, or the most common GI symptom that we deal with in GI clinic. And then also, like Brianna talked about, anorectal dysfunction, problems with evacuating or pushing out the stool as well. So essentially, Parkinson's can affect all the way from top to bottom in the GI tract, and we see a lot of patients with these type of symptoms in the GI clinic. Okay, so why does this happen, or what can cause this in the GI symptom? They looked at the actual GI tract, and you can see the same Lewy bodies as you find in the brain in the GI tract. And the thought is that this can cause pro-inflammatory changes that lead to dysbiosis and of the microbiome within your gut, but also importantly, change the GI motility throughout the esophagus to the colon and even the anus. Another problem is thought to be due to autonomic dysfunction, which we see a lot in Parkinson's disease. And the autonomic system is not only important, or is very important in the enteric nervous system as well, controlling how your gut functions and how it moves. So we see that also. And then we also see side effects from the Parkinson's medications by themselves. Levodopa in particular can slow the GI motility, which compounds all of these problems as well. Okay, so practically what can be done? Highlighting the most common symptom, constipation, kind of what Brianna already talked about. You want to really optimize your fiber intake. This is the easiest thing. We tell this to all patients coming in with constipation, regardless of if you have Parkinson's or not. You want about 25 to 30 grams of fiber a day. Ideally soluble fiber, because insoluble fiber like cereals and things like that can lead to worsening bloating. Things like over-the-counter Optifiber, Citrasil, Benefiber, these things can all boost your fiber intake if you can't eat enough like oatmeal and prunes and vegetables, fruits, things like that. You want to hydrate also to emphasize everything. You want about 6 to 8 glasses of water a day to make sure your gut is full of water so that the colon can move the water that you're consuming. Other tricks were previously talked about. Training your bowel every time in the morning, same time, to get things moving. A warm glass of or warm beverage of some sort can really stimulate your gut to really start moving as well, and stimulate the bowel movement to initiate. And then, exercise, getting moving. This can all promote GI motility as well. The second thing is gastroparesis, so slow emptying of your gut. Practically, what you can do is change how you eat. So things like small meals multiple times a day, instead of 3 large meals, go to 5 to 6 small meals. That allows the gut to empty, or your stomach to empty a lot faster. You can get less bloating, less abdominal discomfort, less complications from a slowed gastric emptying. We usually also tell people a low-fat, low-fiber diet, small particle foods, things you can mash with a fork, like mashed potatoes, proteins, smoothies, liquids, things like that are easier to digest and tolerate than like raw vegetables, fatty processed types of foods. Okay. Things like abdominal, okay. So, and then finally for swallowing and drooling, if this is an issue, certain tricks like sucking on a hard candy or chewing gum can help with that as well. Thickening liquids with some of these commercial thickeners can kind of help you swallow a lot better, and talking with a speech and language pathologist can help as well. All right. So from the medical side, though, if you see me in clinic, there's a lot of pharmacologic therapies that are available. Touching on this briefly, for constipation, the first thing we usually give people is things like Miralax, which is an osmotic laxative to keep the water in the gut and help you go to the bathroom. But there are other therapies like stimulant laxatives, other laxatives that act on different receptors in your colon that can also help in case all these lifestyle modifications don't work for you. For gastroparesis, there are several medications. The only FDA-approved medication is something called Reglan for gastroparesis, but in Parkinson's, it can actually cross into the brain, so that's not a good option. Things that you can get outside the US are things like domperidone and things to stimulate the gut or the stomach to empty. I think you can get it in New Zealand or Canada if you have a connection there. But in the US it's hard to get. And then for like small bowel intestinal overgrowth, there are other therapies like probiotics that might have some function, or some antibiotics to get rid of the bad bacteria and replace it maybe with good bacteria. So hopefully you don't get to that point. But with lifestyle modifications, there are a lot of things that you can do to alter your GI symptoms that are very common in Parkinson's disease. So really the bottom line is to realize that, GI symptoms are very common. We see it all the time. I'm sure your neurologist also sees it, but in GI clinic we see this very commonly. The most common ones that we pay attention to are the constipation and the gastroparesis, or slowed gut emptying, to ensure that you're getting good nutrition, keeping weight on, and moving your bowels. There are lifestyle changes that are important, but yeah, if it ever comes to the point where these lifestyle modifications aren't enough, there are a lot of pharmacotherapies that we have to offer, either in neurology or gastroenterology clinic. Okay, so that's just my short talk. I'm happy to answer any questions. Thank you. Okay, thanks.
We will have all the panelists up here for questions after our last talk. So thank you, Dr. Young. All right, next trivia. I have another $50 Regal Theater gift card, so it's a good one. All right, what type of neurologist specializes in Parkinson's? Movement disorder, yes, very good. Get that too. All right. We got another winner. Okay. Oh, okay. Okay, our last mini presentation before we do the panel is going to be on sleep. So, of course, you're going to get a sleep joke. Okay, why do dragons sleep during the day? So they can fight knights. Okay. All right, our next speaker is Dr. Z for sleep. Dr. Z is an associate clinical professor of neurology at UCSF in San Francisco. He cares for patients with Parkinson's disease and other movement disorders. He's a fellowship co-director of the UCSF Movement Disorders and is a clinical director of the Parkinson's Disease Research Education and Clinical Care Center at San Francisco VA. Aside from treating patients who suffer from movement disorders, his main interest is in helping people with Parkinson's get better sleep as a way to slow disease progression and improve quality of life. All right, I'd like to introduce Dr. Z.
Thanks. All right, how we doing? Thank you for having me. This is really exciting. Aloha, everyone. I also trained in Boston, so I knew Kraig when I was a resident. And then, do people know Dr. Gao? I'm sure she's the most popular doctor in the room. I met Dr. Gao when she was a third-year medical student, and I was a resident on the neurology surface. And even back then, we knew she was going to be an all-star. So you're very lucky to have Faye, Dr. Gao, as your movement disorder specialist. And she invited me to be here, so give her a big round of applause if you don't mind. Cool. So it's always hard to talk about sleep at the end of the day, especially, you've heard all these lectures and it's very easy to doze off, especially if you have Parkinson's. Sleepiness can be one of the symptoms that you deal with. So I'm going to try to keep this engaging. Feel free to, speak up if you see me nodding off during the lecture too, okay? I'm still a little jet lagged from traveling from San Francisco. I did send some slides, but I'll go ahead and just get started if that's cool. Let me just make sure we're on time. Oh no, we got a few minutes. We can just wait for the slides to pop up.
Could you pronounce your name?
Oh, sure. I know Kevin said Dr. Z, which is what I usually go by. But my full name is Rafael Suswaregi. Suswaregi. Yeah, but you can just say Dr. Z, that's cool. It's a lot easier for folks. And somebody asked, where is it from? It's from the Basque region in Spain, so the very northern part by France. Yeah. Yeah, that's pretty good. All right, here we go. Cool. We got them up and running. This is great. So we're going to talk about sleep and Parkinson's disease. This is really important. And I'm going to try to convince you about the importance of sleep for a number of different reasons, not just how you feel and how you sleep, but also slowing the disease progression over time. We talk about exercise a lot as being the main way to slow down disease progression, but I'm going to try to convince you that sleep is probably the other thing that you should be doing or focusing on to slow the progression of Parkinson's, okay? Or other neurologic disorders if you have them. So, can I use this to advance the slides? Cool, all right. So, there's my shout out to Dr. Gao again. So, Parkinson's disease for a really long time was seen as a movement disorder, a motor disorder. Things like tremor, slowness of movement, stiffness, the way that people walk, that was the easiest way to recognize Parkinson's. But as folks who know Parkinson's, either you have it or you help somebody who has it, you know that it's more than just a motor disorder. There are so many non-motor symptoms that can affect you. And Brianna and Kraig talked about this in their presentations. I mean, there's so many things that can affect your body, things you don't even think about. Blood pressure control, your bowel movements, your bladder, the way that you feel, the way that you think, and also your sleep. So we're going to focus primarily on sleep today and try to focus on practical ways that you can help improve your sleep. You can help your loved one improve your sleep. So over 80% of people with Parkinson's experience some form of sleep difficulty during their course with Parkinson's. That's a lot. That's almost everybody. And I think this number probably should be a lot higher. I think almost everybody with Parkinson's deals with problems with sleep. And the way that it can affect your sleep is that it can reduce the amount that you sleep at night. It can cause problems falling asleep at night. And then it can also awaken you from sleep during the course of the night. And I don't know about you, but I hate being awoken in the middle of the night because then I'm real grumpy the next day. So Parkinson's does all this to you, and it really, really is disruptive. And I want to highlight that in some of these studies that have looked at people with Parkinson's who deal with sleep problems, over 30% of people don't talk about this with their neurologist or their primary care doc or their movement specialist. So I want to convince you today, or encourage you, bring this up with your doctor to focus on it. Because again, this is one of the ways that you can slow disease progression over time, and hopefully you can focus on this. So why is getting good sleep important? Clinically, the way that you feel can improve when you get a good night of sleep. Things can improve like tremor, your stiffness, even things like dyskinesias or extra involuntary movements can improve when you get a better night of sleep without changing any of your medication at all. And I've seen this time and time again when we focus on sleep in our patients with Parkinson's. It can also improve the way you think. So your memory can get better. You can also improve what's called visual spatial functioning. It's a really fancy way of saying processing the room around you. People with Parkinson's tend to have some trouble navigating tight spaces, thresholds, turning, going around the corner. And this can all improve when you get a better night of sleep. So it's really important to focus on this so you can feel better. But as I said, this can also serve as a way to slow disease progression over time and one of the main reasons why I focus on this both clinically and in research. So I have this abbreviation up here, SWS, and that's slow wave sleep. This is the deepest part of sleep that you get into. And it's really important to get that sleep because it helps slow disease progression. It also helps with your motor symptoms. And studies that have looked at this have shown that when you have a reduction in the amount of your slow wave sleep, your motor symptoms are worse. So we want to try to get that to a better place so you feel better. And then on a cellular level, people have tried to understand how do these decreases in your deep sleep impact you and your disease. So there's this protein that you may have heard about called alpha-synuclein. Show of hands, who's heard of this protein? Okay, a handful of folks. Alpha-synuclein is a protein that we think is the main driver of Parkinson's disease. And so people have studied the levels of alpha-synuclein in patients with Parkinson's who have gotten poor sleep when they're awake and then after a good night of sleep. And you can see here that people who have a disrupted night of sleep when they wake up in the morning have the highest level of that abnormal protein that leads to Parkinson's, as compared to somebody who's just awake and as opposed to somebody who's asleep. So I think this is the main reason why we want to try to reduce the amount of sleep disruption that you have, because it'll help your brain clear that abnormal protein better so you feel better the next day, you move better, you think better, and also slows the disease progression over time. I'm going to feel like a broken record saying this because I think it's so important, but this is huge. This is a really big deal, and I think hopefully you can focus on it in your life too. So the way that I try to think about sleep problems in Parkinson's is categorizing them into the things that you feel, that you experience. So thinking about it as motor symptoms, you all deal with tremor, stiffness, slowness of movement. That can disrupt your sleep. Non-motor symptoms, Brianna and Kraig talked about those types of symptoms that can affect you. That can also bother your sleep. And then also there are other sleep disorders that can impact your sleep too. And we can't cover everything. I'm thankful to Kevin for giving me 45 minutes to talk about sleep. This could be like a 2 or 3 hour talk easily. So we're going to try to focus on things in 45 minutes to help you get a high yield way of focusing on your sleep for Parkinson's, okay? All right, and then just a reminder, anything that I recommend in this talk, take with a grain of salt and talk with your physician about this, okay? So feel free to take pictures of the medications I talk about and other things that I recommend. So you can bring it up later with your doctor. This is not like, I'm not telling you what to do, it's just some guidance on this. Okay, insomnia. Who here has had trouble falling asleep or staying asleep during the course of the night? Show of hands. Okay, yeah, that's about a third of the room. This is something I deal with from time to time, and I feel like this person on the picture here, I mean, it just really ruffles my feathers when I don't get a good night of sleep. And so we define this as difficulty falling asleep, staying asleep, or waking up earlier than expected, getting a shorter sleep time for at least 3 days a week over the course of 3 months. Honestly, if you're having this problem for a week or two, it's something that I want to focus on with you as a movement disorder specialist. So don't wait 3 months to bring this up to your doctor, okay? If you're having it, talk about it so you can improve your sleep. And as you can see, it's a really common symptom. I think this underrepresents the number of people with Parkinson's who deal with insomnia. It's probably 75% or more. But this is what the studies have shown so far. Okay, so we talked about that framework for thinking about sleep problems in Parkinson's, motor symptoms, tremor, stiffness, slowness of movement, and dystonia, which is an abnormal sustained muscle contraction that can waken you from sleep. This is when your medication levels are lowest. So things like toe cramping, your toes curling, maybe your hand tightens up and curls in, maybe your neck gets uncomfortable because it's pulling to one side. Things like that can awaken you from sleep. Non-motor symptoms of Parkinson's, Brianna talked about urinary issues and how to focus on that. That's really cool and really helpful. And then depression and anxiety, which are really common in Parkinson's, can also impact your sleep without even realizing it. And then we'll try to cover a couple of other sleep disorders that are very common in the general population, but also in Parkinson's, and ways to try to navigate those. Restless leg syndrome and then obstructive sleep apnea is the other. Folks heard about sleep apnea and restless legs? Show of hands. Okay. All right, so a fair amount of people have heard about these. Cool. So what's the underlying problem? When we talk about your sleep in Parkinson's, we want to focus on the underlying issue that's leading to the insomnia. So again, motor, versus non-motor symptoms of Parkinson's or the other sleep disorder, and then we individualize your treatment. It's not a one-size-fits-all for everybody. So thinking about motor symptoms, this is really common. Show of hands, how many people deal with tremor in the room? How many people deal with stiffness or feeling like they're moving slow? Okay, so even more people than those with tremor, which can be more common symptoms than Parkinson's. And it's been shown that people who have trouble moving in bed because of that stiffness from Parkinson's have trouble sleeping. It awakens you during the course of the night, makes it hard to fall asleep, and that's really uncomfortable. So we want to try to focus on that and treat that. The longer that you have Parkinson's, of course, the more motor symptoms that you have or the more severe that they are. So again, talking about this with your doctor to focus on it can be helpful. So what are some of the things that we do to help you with your motor symptoms during sleep? I'm going to talk about treatments that have been studied and then talk about some treatments that we just use in practice to help people with Parkinson's who are having motor symptoms. Show of hands, people know what Sinemet CR is, or carbidopa-levodopa extended release? Okay, raise your hands if you know what carbidopa-levodopa is. Okay, so everybody raise their hands, okay. So carbidopa-levodopa is the most common way of treating motor symptoms of Parkinson's. But at nighttime, that medication only lasts for a few hours. So many years ago, they devised a way of giving you an extended release version of this for trying to make that carbidopa-levodopa last longer through the night, and that's what Sinemet CR is. This is a really common strategy that's been shown to help people with stiffness, tremor overnight. It's one that I use really commonly. Dr. Gal probably uses it a bunch too, to treat people who are having those motor symptoms overnight. And then rasagiline is a different class of medication that helps to extend the life of that carbidopa-levodopa during the course of the night, and that's also been shown to help with tremor and restlessness and stiffness overnight. It's a MAO-B inhibitor. That's the class of medication that it is, so a little bit different than carbidopa-levodopa. There's another class of medication that's been used too called dopamine agonist. It's similar to levodopa, but it's already sort of processed into dopamine, which is what levodopa gets changed into. And that's what really helps with your symptoms of Parkinson's, the movement part at least. So things like retigotine patch, it's a patch that you can put on your body and it stays on for the whole day. So it kind of lasts and gives you medication all throughout the day and night. That's something that can help with your tremor and dystonia as well, can also help with your sleep. And then things like pramipexole and ropinirole, which are oral medications that you can take, have also been shown to help with those motor symptoms of Parkinson's overnight. Now I want to talk about some of the newer treatments. In underserved and areas that don't have access to a lot of resources, may find these a little bit more tricky to get access to depending on your insurance, but I still want to bring it up to you all as a way of just exploring it as an option to try to help treat you. In people who take carbidopa-levodopa and they experience what's called wearing off, this is when your medication effect starts to drop off after a few hours and you start getting that tremor, that stiffness, that slowness of movement. We try to combine short-acting and long-acting carbidopa-levodopa as a way to help you with that. And that can actually be really helpful for your sleep. So medications like Rytary, have people heard about Rytary as a medication? It's only a handful. These are newer medications that have come out in the past 10 years that combine those short-acting and long-acting levodopa, and they've been shown to help people with their sleep. So things like Rytary, Crexon is a really new one that came out 2 years ago, and then just recently, within the past year, Vyalev is a subcutaneous levodopa pump that constantly gives you levodopa over the course of the day, has also been shown to be helpful with sleep. So I realize that there may not be easy access to these things. They may be expensive, but I want to bring them up so you're aware of them as a way of treating your motor symptoms. Have people heard about deep brain stimulation? Okay, a handful of folks. Deep brain stimulation is a way to treat Parkinson's disease. And there's sort of specific guidelines for how to do this, but in people who have deep brain stimulation, that's been shown to be helpful for things like tremor, stiffness, slowness of movement. It can really help us sleep. It's not the main reason why we do deep brain stimulation, but I bring this up because it's helped us learn a lot about what's going on at night in people with Parkinson's, and I'll talk about that a little bit later in the talk. In fact, the next slide. So this is a research project that we did at UCSF looking at people with Parkinson's who had deep brain stimulators. There's this new technology that allows us to read your brain activity in real time. It's unbelievable and I can't believe that we have this kind of information. But we use this to study people with Parkinson's who are having problems with their sleep overnight and trying to understand what's going on and what's waking you up during the course of the night. So what you can see in this green box is that there's this increase, let's see here. In this green box here and over here, that doesn't go quite as far. This is demonstrating about 20 seconds before somebody with Parkinson's disease wakes up at night. And that deep brain stimulator is recording the brain activity. And what's happening right before that time that you wake up is there's brain activity that corresponds to stiffness and slowness of movement that starts to increase even before you wake up. And this is pretty remarkable because we didn't really understand this about people with Parkinson's. People who are just waking up, we didn't know why it was happening. But now we think that the disease is creating your symptoms before you even wake up. And so what I've done in my own clinical practice with this information is I've started putting more people on levodopa at bedtime to help them get better sleep. And what it does, it's pretty remarkable that levodopa only lasts for a few hours during the course of the night. But for many people, when they wake up the next day in the morning, they feel like their symptoms are better. Tremor, stiffness, slowness of movement, dyskinesias. And that's because that the levodopa is helping to suppress this brain activity and allow you to sleep better through the night. So this has been a really remarkable breakthrough in allowing us to understand what's happening to you all when you're sleeping. And it's changed the way that I practice as well. Okay, so let's talk a bit about non-motor symptoms. And actually, let me pause there and see, do people have questions about what I just talked about with the motor symptoms? No, we'll have a Q&A too, so I'm sure that there will be questions that pop up. I just like to keep it interactive because hearing me drone on for 45 minutes can probably make people fall asleep. All right, so let's talk about non-motor. Yeah, oh, there's some questions in the back. Great. Hours of sleep per night. Well, that's a really tricky question because it's individual to everybody. Some people can sleep shorter times and some people need longer times, and that's a genetic thing that is passed along in families. I think in general, the recommendation that we give folks is to get at least 7 hours of sleep per night, up to about 9 hours.
How much is REM? How much is non-REM?
Oh gosh. The recommendation for that is a little bit trickier. Maybe we'll save that for the Q&A. But in general, you want about a quarter of your night to be in REM, and you want about 30% of your night to be in deep sleep. These are not things that you can actively do. It's just kind of how your brain works. And the better that you sleep, the less interrupted that your sleep is, the easier it is to get those numbers, during the course of the night. Yeah.
Going back to that chart, where you have that, that chart shows, okay, so
Sure.
right here is down low. Is that with medication prior to the green box?
So this is actually just during deep sleep.
Okay.
So I talked earlier about the importance of slow wave sleep or deep sleep.
Right.
This is measuring the brain activity when somebody is in deep sleep. And this is actually without medication here. This is somebody who has a deep brain stimulator implanted, and we didn't give them medication overnight, and we're just reading the brain activity. And so what's happening before somebody wakes up, somebody with Parkinson's wakes up, is that they have this ramp up of brain activity that corresponds to stiffness and slowness of movement.
So what's happening between brain activity to muscle? What's triggering it to be stiff right as it's starting to wake up?
So the question is, what's causing this increase here in brain activity, and how does that correlate to the stiffness that people with Parkinson's experience? It's part of the disease progression. So our brain is just a big tangle of circuits and electricity that's talking from one part of the brain to the other. And Parkinson's disease impacts that in a negative way and disrupts the way that the brain talks to itself and other parts of the body. And so when this increase is happening here, this happens during the daytime too, that corresponds with stiffness and slowness of movement. But this is happening at night before people even wake up, which we didn't know before. And so we use that levodopa to help treat this and suppress it and get people better sleep throughout the course of the night. It's pretty remarkable. Okay, So let's move on to non-motor symptoms. I want to make sure, and I'm good until 11:15. Cool. I just want to make sure I stay on topic or on track. So Brianna gave a great presentation about urinary symptoms and physical therapy for that. So I'm not going to talk too much about urination problems, which can impact your sleep. We'll talk about some of the medications that you might consider using when things like behavioral interventions or physical therapy aren't helping you as much. But nocturia is a really common symptom that people with Parkinson's experience. And nocturia means getting up at night to urinate. You're asleep, then you wake up and you have to go pee. How many people in the room deal with this symptom? Wow, that's actually quite a bit. I know the number here says 35% of patients with Parkinson's deal with this. I honestly think this number is probably above 50%, and Brianna probably, sees a lot of this in her clinic, quite frankly. And when you have to get up and urinate at night, it's incredibly disruptive because number one, you have to get up, and then number two, many people have trouble falling asleep. And as Parkinson's disease progresses, you can have worsening of this problem over time. I can't tell you how many folks come into the clinic and say, Doc, I wake up 5, 6, 7 times a night because I have to get up and go pee. So it's really problematic and something that we do want to focus on. I'm really glad that you heard the talk from Brianna today. So some of the things that she probably talked about and some of the things that we focus on are reducing the amount of water intake by the afternoon. Your body processes all this water that you're drinking. And if you're drinking it in the evening, when does it process it? At nighttime, bingo. So what we tell people is when you're trying to get that half of your body weight water intake in, you're going to try to do that in the morning, okay? So that way you're not waking up at night processing all that water and then, waking up to go pee. Some people take medication for blood pressure that causes you to go pee. We call those medications diuretics. I see some shaking heads in the room. Yeah, I'm on that. That can make you go pee, right? And so sometimes people take that at nighttime. And a real easy thing to switch is to move that to the morning. So that way your body processes that medication by the time that you're ready to go to sleep. And then you're not peeing as much overnight. I should include physical therapy referral on here to work on the exercises that Brianna talked about, which are incredibly helpful. But as a neurologist, a movement disorder specialist, once we get past, hey, we've tried these behavioral interventions, maybe we've tried some medication, oftentimes we'll ask our colleagues who specialize in urinary problems to, give us some insight into what the urinary problem is. For older men, and I see a number in the room, an enlarged prostate can be a problem that makes you go often and makes you feel like you have to go quickly. That's not something that I am really skilled in treating, and so having our urology colleagues focus on that and help you with that can be helpful. Urology also provides other expertise in terms of the medications to help treat this issue. So this is a reason why I like to partner with them if that resource is available. So what are some of the medications that we use to treat urinary problems overnight? So these medications have been studied in elderly populations. Not all of them have been studied in Parkinson's, but we use these 3 medications primarily because they help to avoid side effects that people with Parkinson's commonly deal with. So the first medication on this list is called trospium. This is a medication that we use a ton in our practice. The other name for it is, I'm blanking. Sanctura is the other name for it. That's the brand name for trospium. This is a medication that has been shown to be safe in people who have memory problems. People with Parkinson's tend to develop those over time. So we like to use this medication to reduce the amount of urinary issues that you have overnight. The other medication that we use is called mirabegron. This is a medication that's been found to significantly reduce the amount of urinary episodes that people with Parkinson's has overnight. It's been studied in people with Parkinson's, so that's why we like to use it. And then solifenacin is the other medication that we try to use to, again, reduce the amount of times overnight that you go pee, and this has been shown to be helpful for that as well. Once we've gone through physical therapy, we've tried to adjust your lifestyle, we've tried all these medications to help you. If that doesn't work, I like to get our urology colleagues involved to see if they can help you manage this with something called Botox. Do people in the room, have people heard about Botox? Show of hands. Probably for Hollywood reasons, right? You've heard about Botox, but we use it a ton in neurology and especially in movement disorders for people who have dystonia of the neck or other parts of their body. But Botox is a medication that can be administered to help calm your muscles down. And so the bladder is basically a big muscle. It's contracting and expanding. And in people with Parkinson's, it tends to be, like Brianna talked about, it tends to be overactive. So that big muscle balloon isn't able to expand all the way, and Botox can be injected into that muscle to allow it to expand and fill up so you don't have to urinate as often. Okay, so let's talk a little bit about mood disturbances. For the people with Parkinson's in the room, who has dealt with depression or anxiety as part of their disease? Okay, that's a fair amount of hands. That's probably a quarter of the room that's dealt with this. This is really common in Parkinson's disease, and it can lead to problems with falling asleep and staying asleep. Regardless of whether you have Parkinson's or not, these are two things that should be focused on. And one of the ways that we manage this without medications is to use a behavioral therapy program called Cognitive Behavioral Therapy for Insomnia. It's a 6-week program that walks you through understanding your sleep better. And then it gives you different techniques and exercises that you can do with your brain to help calm your brain down and then get to sleep faster and stay asleep longer through the night. And it's been shown to be helpful in people with Parkinson's disease, not only in the 3 months that this therapy was administered, but also for the long term after that. So I think it's really helpful to focus on cognitive behavioral therapy if you're dealing with depression, anxiety, and you're having trouble with your sleep. This is one thing that we can do to help. So doing this in person can be really tricky, even in San Francisco. There's just not a lot of people who provide this one-on-one. And so what I've tried to do is come up with a list of applications that you can download on your phone to help you go through this behavioral therapy program. So CBTI Coach is one that was developed through the VA system. It can be really helpful for people. There's also the Calm app, Headspace, and Sleepio. These are all things that you can download on your iPhone or your Samsung or whatever you use. And some of these are free. Some of these you have to pay for the service. But I think it's just really easy because we all have phones, we all have access to this. So this is a really cool way to do it. If you don't have a cell phone, if you don't like using a cell phone and you prefer to use like a laptop or a desktop or whatever it might be, then you can actually go to a website on the internet and go through this program. Any veterans in the room, just out of curiosity? Okay. There's a handful of veterans. First of all, thank you for your service. I work at the VA half-time, and it's a really important part of what we do is treating our veterans who have Parkinson's disease. For the veterans in the room, there's actually an application through the internet that you can go through called Sleep Easy to navigate this behavioral therapy. For those who don't go to the VA or are not a veteran, you can use Somrist. And if you just type this into your Google web browser, it'll pop up with the website, and then you can look at the program and use it from there. Okay. Earlier I talked about slowing the disease progression over time. And I wanted to really focus on sleep, although exercise is one of the other ways that we can slow the disease progression. Exercise can also be really helpful for sleep, regardless of whether you have depression or anxiety. But I list it here because it's been studied in people with Parkinson's who are dealing with those mood disturbances, and it's a way that you can really help improve your sleep. So people who are doing cardiovascular exercise, weightlifting, I think I heard Pilates earlier. Dr. Young was going to give a class on Pilates for everyone. Tai Chi, yoga, all of these exercises can be helpful for your sleep. The idea is to do this over a long period of time if you can. I realize that Parkinson's can affect your mobility, but doing some sort of exercise program that's consistent with your mobility level can really help you to get better sleep at night. And you just feel better. Your mood gets better, your thinking gets better. I woke up kind of grumpy today, so I worked out, and now I'm feeling a little bit better too. So I didn't want to be grumpy when Dr. Gao showed up to pick me up. But this is really important, exercise and sleep. 2 ways to slow disease progression, 2 ways to improve your sleep, okay? All right. I did want to talk a little bit about how to treat this in people with Parkinson's, because access to mental health can be really tricky in under-resourced areas. And Hawaii is like where I grew up. I grew up in a small town in California that doesn't have a lot of access to specialists. So what I want to try to give you is a framework for how to navigate this if mental health is not something that you have easy access to. So for depression and anxiety, we often use antidepressant medications. People have heard of SSRIs, that type of medication, show of hands? Okay, so a handful of people. SSRIs are a medication. It stands for serotonin, selective serotonin reuptake inhibitors. What they do is they help to increase the amount of serotonin in your brain. It's basically a happy chemical, is what I like to say it as. And these medications can be helpful for both depression and anxiety. And in Parkinson's disease, the two that we use the most are probably sertraline and mirtazapine. Mirtazapine is the one that I like to use the most in people with sleep problems because at low doses it can help you to fall asleep easier, but then it can also help with your mood, with your depression and your anxiety. So that's one that I use pretty commonly, and then sertraline as well. There are others that have been studied in Parkinson's disease: escitalopram, venlafaxine, and then bupropion. Those are probably the other three that we use pretty often and are recommended by our Movement Disorder Society for people with this issue. I do want to exercise a little bit of caution in using these medications because some people can have problems like restless legs overnight, or people with Parkinson's can also act out their dreams. You may have heard of someone or experienced it yourself where you kind of hit your partner during sleep or you kind of thrash around. We call that REM behavior disorder. These two sleep disorders can be worsened by some of these medications. So again, I bring these up as a way for you to talk about it with your doctor and choose the right medication for you if you are dealing with depression and anxiety. Okay, but what if there's not a clear cause for your sleep problem? What if you don't have depression or anxiety? What if you're not waking up with your toes curling or tremor, and you're just waking up in the middle of the night? What do you do for that? A lot of times people just use medication, right? The better sleep you get, the better you feel, so you try to focus on it. I like to direct people towards what's called sleep hygiene. These are behavioral interventions that you can easily do to help try to create a routine for you to help your brain learn a habit of when I need to fall asleep and can I stay asleep through the course of the night. So for everybody who has an iPhone, this is really hard to do, but putting your phone away an hour before bed, gosh, that's so hard. I don't know, I'm always checking email at nighttime. I'm sure Dr. Gallo and Dr. Young do the same thing. But that blue light from your phone stimulates your brain to be awake, whether you realize it or not. And so shutting that off, turning your TV off, turning your computer off, and putting that to the side an hour before bedtime allows your brain to calm down and then prepare itself to then fall asleep much easier than if you're scrolling through Instagram or Facebook or whatever it might be. The other thing that we ask people to do is for your sleep, make the bedroom strictly for that, or sex. Nothing in between. Don't eat in bed, don't do work in bed. Leave the bed for sleep. And that allows your brain to get used to this idea of when I get into bed, it's time to fall asleep, and then I can stay asleep through the course of the night. It's creating that habit for yourself. And then finally, the other thing that can be really helpful, which is hard in this day and age, is to create a really strict sleep schedule. And what I mean by that is having the same bedtime every day and having the same wake time every day. That can also include your wind down time. So, when you start brushing your teeth and getting ready for bed, creating this schedule for yourself to allow your brain to learn that, okay, it's time to shut down, it's time to go to sleep. And that can be really helpful too. I think we all lead really hectic lives. There's a lot of appointments. There's a lot of messages you're getting from family or friends. So putting that aside before you go to bed can help your brain really to calm down, okay? All right, and then I wanted to talk a little bit about medications to help with sleep, because we get this question so often. Hey doc, can you give me a medication to help with my sleep? I'm not really sure how to navigate this. And again, this slide is really for people who don't have a clear cause for why they're having trouble falling asleep or waking up in the middle of the night. I want to make a note that there's a few medications out there that really should be avoided. Have people heard of Ambien? That medication's been around for a long time now. And it's a really common sleep drug, right? It's kind of, for a while there, it was being given out like candy to people who are having sleep problems. Medications like Ambien, Lunesta, or other medications that are called benzodiazepines like Ativan, clonazepam, Xanax is another popular one that people have heard about. These medications have actually been shown to increase the risk of worsening your cognition over time. So in people with Parkinson's who already have a risk of developing cognitive problems, you don't want to accelerate that. You don't want to put yourself in harm's way. So really we try to avoid those types of medications for people with Parkinson's. Things that I like to use when there's not a clear reason for why you're waking up are melatonin. Melatonin is a really easy supplement to get over the counter at CVS, Walgreens, whatever it might be, whatever store that you go to. And melatonin is a natural hormone that your body produces before you're supposed to go to sleep. So it increases the secretion of that melatonin, and it signals to your brain and body, hey, it's time for me to get to bed, and then allows you to do so. So melatonin is one that I really use commonly. There's another medication that's been studied recently in people who are over 65, and this medication called doxepin. And at low doses, it was shown to be safe cognitively for people over 65 and was helpful in allowing them to fall asleep. So I've started to use this a little bit. It's a really common medication and easy to get. And I would caution that when you bring this up, if you are going to bring this up with your doctor, to use a low dose only, because it's been studied at the lower doses. And then finally, the last one is trazodone. And trazodone's an old school medication that's been used for depression and anxiety for a long time. But only recently it was studied in Parkinson's disease and shown at low doses to be helpful for sleep. So I've started to incorporate this into my own practice of using trazodone for people who are having problems falling asleep. Okay, so thinking about insomnia, what are the take-home points here? So when you're dealing with this sleep issue, you want to identify what the cause is. Is it a movement problem, a motor symptom, I should say? Is it a non-motor symptom? Or is it some sort of other sleep disorder, which we'll touch on in a second, that's interrupting your sleep? And bring this up to your doctor so you can then treat on it. You can then treat it. And the treatment of these symptoms are really tailored specifically to you. It's not a one-size-fits-all. It's not like one medication works for everybody. What is the issue you're dealing with? Bring it up, treat it, and then see if your sleep gets better. Okay, let's see. I've got about 12 minutes. I see a couple of yawns in the audience. I know we're getting close to lunch, and that's when people start to get a little more tired. But we're going to talk about a really important sleep disorder that can impact your sleep. How many people have heard of restless legs in the room? Raise your hand. Wow, so probably there's a lot of people who have heard about this. Restless legs, as you can see from the photo here, can lead to a really restless night. And the way that that restless legs impacts your sleep is that it creates an urge to want to move your legs because it creates an uncomfortable sensation. And then the old papers that described this initially, people used terms like the heebie-jeebies, creepy crawlies, spiders crawling on my legs. Numbness and tingling is the most common one that I hear, but it's a really uncomfortable sensation that can be hard to describe that then creates, this movement. And that movement can help to improve that discomfort. And that discomfort tends to happen really at nighttime and when you're resting. And this happens a lot in people with Parkinson's disease, believe it or not. About 35% of people with Parkinson's deal with this. I think it's a little bit higher, actually. But it's a big problem because it tends to happen at night when you're trying to go to sleep. So when you're sitting in your chair watching TV, watching the evening news, or you're lying in bed, then this urge to move your legs comes up. And sometimes people thrash around in bed like in the photo. Other people get up and walk around their house. And how can you go to sleep if you have to walk around to get rid of this sensation, right? So one of the things that we want to do is really treat this. First of all, diagnose it and then treat it. The diagnosis is basically just talking with your doctor. Hey, this is what I'm dealing with. I'm having these heebie-jeebies. It's making me get up at night and walk around, and it's affecting my sleep. So bring this up with your doc if you do have it, and then we're going to talk about how to treat this. So in people with restless legs, oftentimes their iron levels might be low. And so you want to get this tested, of course, if you are dealing with restless leg symptoms, and then treat that. It's a pretty easy thing to do. You can go to CVS or Walgreens, get iron over the counter, and then treat it, if that's the issue. Now, if you don't have an iron problem, and you need medication to treat it because the symptoms are so bothersome. The medication that I really recommend for folks with Parkinson's to try is gabapentin. Gabapentin is a medication that's been around for a long time. It used to treat seizures, but we use it really in movement disorders to help with restless legs. Generally, I think it's pretty safe, and at low doses can be really effective for restless legs. There are some similar medications to gabapentin like Horizon, which is a long-acting form of gabapentin, and then Lyrica, which is formulated a little bit differently. But all of these have been studied and shown to be helpful for restless legs if you're dealing with it, okay? And then, of course, for people with Parkinson's, you take Sinemet, you take carbidopa-levodopa, and that can be really powerful for treating restless legs. And it kind of goes hand in hand with that idea that I was talking about earlier of using that extended release carbidopa-levodopa overnight to treat your sleep. You can do the same thing for restless legs and really help with these symptoms. Now, for folks who are dealing with this, I want to caution you about a class of medication that we talked about earlier. We treat Parkinson's disease with medications that replace dopamine. So you might be on Sinemet, you might be on rotigotine, ropinirole, and the latter two are in this class of medication called dopamine agonists. Dopamine agonists for people with restless legs can paradoxically cause a worsening over time. And it can lead to big problems with having to escalate your medication to higher and higher doses. And in people with Parkinson's, you might experience what we call impulse control disorders. These are disorders where people feel like they have to snack impulsively. They might surf the web for porn. They might online shop, jump on Amazon, buy a lot of stuff, might go to the casino and go gamble. And these can be really big problems for people who are on these types of medications. So I want to caution you, if you have restless legs and you're taking one of these and you're experiencing worsening of your symptoms, the idea is to get off of them and try one of the other medications that I suggested. But you want to talk about this with your doctor first, okay? I feel like this is really coming to light in the past 5 to 10 years, and it's really important to understand how this might affect your life. Okay, I've got about 7 minutes left. We're going to talk about sleep apnea. People in the room, do you sleep with somebody, in the same room who snores? Show of hands. Okay. My family is full of snorers, and it's the worst when we all get together and go on vacation because we're in the hotel room and people are just snoring the night away, right? And then it really affects your own sleep. Snoring is sort of a surrogate measure or a surrogate symptom for sleep apnea. Sleep apnea is a problem with breathing during night where you have trouble getting air into your lungs, or you might completely stop breathing in the course of the night. And that can be really scary as someone who's sleeping with another person in the room who just absolutely stops breathing. It's really frightening. But sleep apnea can have a really big impact on people with Parkinson's disease. I want to highlight a few other symptoms that might correspond with sleep apnea. Things like awakening during the course of the night multiple times, sometimes with a dry mouth, sometimes coughing or choking. Daytime sleepiness, which is already a problem in Parkinson's but can happen because of sleep apnea, and then taking multiple naps. So if you have a combination of these symptoms, that might represent that you have sleep apnea, and it's a good idea to bring it up to your doctor to get diagnosed and treated. So in people with Parkinson's, who have sleep apnea, why do we care about this? One is that it can cause daytime sleepiness, as I mentioned, already a problem in Parkinson's. Number two, it can impact other medical issues like high blood pressure, diabetes, high cholesterol. It can increase the risk of strokes, heart arrhythmias, and problems. And it can also worsen your cognition. We talked, about how Parkinson's can create a risk for worsening cognition, the way that you think. Sleep apnea does this, so it's sort of a synergistic issue if you have sleep apnea and Parkinson's. So we want to treat that. People with Parkinson's who had sleep apnea were studied and compared to people with Parkinson's who did not have sleep apnea. And it turns out that folks who had sleep apnea tended to have worsening cognition. I just want to highlight this point again and why it's important to get this treated. So how do you diagnose this? Well, oftentimes you can just diagnose it by telling me that you snore or stop breathing during the course of the night. That's really easy, right? But insurance companies don't care about that. They want to see that you have sleep apnea and meet the criteria for getting treatment. So this really requires a referral to a sleep specialist and undergoing a sleep study in order to diagnose this. And once you get that test and it shows that you have sleep apnea, There's a few different ways to treat this. Really, the best way to treat this is using what's called a CPAP machine. A CPAP machine, you may have heard about or seen about on TV. It's a machine that provides air to you while you're asleep. It's a machine that's connected to a tube that goes to a mask, and you wear it at night. And that machine is delivering air to you to keep your airway open, so you don't snore, you don't stop breathing, and it can help you get really restful sleep during the night. I use the CPAP machine, full disclosure. So when people tell me that they're having problems with using CPAP, I'm really invested in trying to help them navigate that and troubleshoot it so they can use it. But it can be hard. It's not very comfortable. So what are the other ways that you can treat sleep apnea? There are oral appliances that you can use. These are like basically like mouth guards that interlock and help push your lower jaw forward to help you sleep better and not snore as much and not stop breathing during the course of the night. There are little nasal strips that you see athletes use that you can just put on in the night, and it helps to open up your nasal passage so you don't have to use your mouth to sleep. When we open our mouths during sleep, that's when we tend to go and snore, and then our tongue falls back and it can actually cause us to stop breathing. So if you open up that nasal passage, it can really help you breathe better and reduce the amount of sleep apnea that you might have. People who have allergies get really stuffed up here. And so if you focus on treating the allergies, again, the idea is to open up that nasal passage, help you breathe better, and treat that sleep apnea. And then finally, this is like my grandpa's strategy, sleep in a recliner. So he'd get in that lazy boy, and whenever he would be fully reclined, he'd snore. So we'd put the recliner a little bit up, and the snoring would get better, and then he wouldn't be as tired when, the next day. So that's kind of an easy one. You can also prop up pillows. That's another way to reduce the impact of gravity on your snoring. And those are just kind of behavioral things that you can try to help treat sleep apnea. Okay, and this is just demonstrating the point that CPAP can significantly improve sleep apnea. It treats it. That it can improve the amount of oxygen that you get during sleep. But then also it can help with that daytime sleepiness problem that's really common in Parkinson's disease. And so think about this. If you have sleep apnea, think about getting diagnosed and treated because it can really help with your quality of life. Okay, I think I have 2 minutes left. Cool. Thank you all for having me.
That's fantastic.
Right on, thank you.
All right. So we'll do one more trivia, and then we'll take a 15-minute break. And then we're going to bring all the speakers up, plus more, and we're going to do a Q&A panel. So start thinking about your questions. Some were pre-submitted, so I'll get it started. But we will have a microphone. So if you have a question, just raise your hand and we'll get a microphone to you. I will repeat the question, and then we'll pass it on to our panel. Okay, trivia time. All right, this is going to be a little bit easy because Dr. Z talked about this. Is which protein, when accumulates abnormally in the brain, is linked to Parkinson's disease? Alpha-synuclein. All right, we got a winner.